So I was asked to talk about this really important area of omega-3s in cardiovascular health. Although this is a science update, a lot of what I'm going to say actually is of historical significance, because I think it's important to get a good global overview of the area. Cardiovascular disease, of course, is a disease of the blood vessels, ultimately affecting supply of blood to a tissue, perhaps the heart, in the case of what we call coronary heart disease, the brain, where the manifestation may be stroke, or peripheral regions of the body, which is peripheral vascular disease. There are two components to cardiovascular disease. The first is the buildup of the fatty deposit in the blood vessel wall, that's called atherosclerosis, and the second is the element of blood clotting or thrombosis. And these could be influenced together or independently by omega-3 fatty acids. Cardiovascular disease is a very complex disease that starts early in life, and the outcome may not be seen until rather late in life, many decades after the initiation of the disease. Of course, when many people think of cardiovascular disease, they think of blood cholesterol. Cholesterol is only one of many risk factors for cardiovascular disease, and one of the interesting things about the cartoons that I'm going to show you now is the emphasis is very much not on cholesterol, but on other important risk factors for cardiovascular disease, particularly inflammation. So this is the early stage of the buildup of the fatty plaque, showing the interaction between white blood cells in the endothelium and the movement of white cells into the blood vessel wall where those cells become activated. So this cartoon is saying inflammation and immune interactions are central to the initiation of the process of atherosclerosis. Later on, again looking in the blood vessel wall, we see immunological pro-inflammatory interactions between lymphocytes and the macrophage-derived foam cell as being central to the buildup of the fatty plaque over here. So again, a focus on cellular interactions within the blood vessel wall and a role of the immune system and inflammation. Of course, the end product of these processes is the buildup of the atherosclerotic plaque, which you see here. So this is a cross-section of the coronary artery. So the vessel lumen should be this diameter in this individual, but you see this immense plaque which has been built up as a result of those processes shown in the earlier cartoons. Later on, a cardiovascular event, as it's called, a myocardial infarction or stroke, something like that, is often precipitated as a result of the rupture or the breaking of the atherosclerotic plaque, opening it up to the possibility of formation of thrombus. And again, in this cartoon, you see the key role of immunoinflammatory activity in driving a cardiovascular event. So inflammation is pretty important in the process of atherosclerosis, the buildup of the plaque, and in the process of the rupturing of the plaque that gives rise to the cardiovascular event, a myocardial infarction or a stroke. So again, this is a cross-section through a coronary artery with the thrombus or the clot here. The plaque was here and is ruptured at its edge here, which has initiated the buildup of the thrombus, which has cut off blood flow in the case of this individual who died as a result of that cardiovascular event. The focus on cardiovascular disease has always been very strong in the omega-3 world and elsewhere, and the reason for that is this is a very common disease. 1 in 3 people in the world now, in 2016, will die as a result of cardiovascular disease. That is 18 million people every year, or 49,000 people every day. These are big numbers. 49,000 people will die today in the world as a result of what you've just seen in those cartoons. So these are very big numbers we're talking about. So this is a huge target for improvement in risk profile and reduction in events. Let's move now to the omega-3 story in relation to cardiovascular disease. So the story, of course, began with the classic studies of Bang and Dyerberg in particular, which you'll hear more about, I'm sure, later on, in the Inuit populations initially, but then these data were replicated in native populations in northern Canada and in Alaska, and similar things were found in the Japanese. and that is a much lower than expected incidence of manifestations of cardiovascular disease, in this case, the proportion of the population dying from myocardial infarction. And this was traced through the work of Bang and Dyerberg to the diet of the Inuits, which was very much based on sea mammals, including the fat of sea mammals, resulting in massive intakes of EPA, DPA, and DHA, which is something like 100-fold greater than a typical Western intake of these fatty acids might be. Of course, it's important to gather data in Western populations consuming more typical diets to see what is going on with omega-3 fatty acid exposures. This is epidemiological data from the Nurses' Health Study showing the relationship between intake of omega-3 fatty acids, this is EPA plus DHA, and risk of coronary heart disease, dying of heart disease, and having a myocardial infarction, showing a reduction in risk with increasing intake of EPA and DHA. And of course, the highest intake would come from eating fatty fish or taking omega-3 supplements. And you see the risk reduction in this epidemiological study was of the order of 50%. This is another epidemiological study, the Physicians' Health Study, but in this case, omega-3 fatty acids were measured in whole blood and were related to the relative risk of sudden death over the period that followed the blood taking, showing that as omega-3 fatty acid status in the blood was increased, the risk of sudden death was increasingly decreased, and this was particularly important to note that this is after adjustment for all other known risk factors for cardiovascular disease. So I think these are quite strong findings. You're going to hear a lot, I think, tomorrow about meta-analyses. Meta-analysis is where researchers bring together data from other studies and put that data together to come up with perhaps a more statistically robust outcome. That's the idea, increasing statistical power. But of course, what happens in a meta-analysis is very much determined by the studies that are included in the meta-analysis, and including different studies can influence outcome. This is the much maligned meta-analysis of Chowdhury from Annals in Internal Medicine, which demonstrated that saturated fat intake wasn't associated with coronary outcomes. What's overlooked when people talk about this meta-analysis, and it's not mentioned in the abstract, is the meta-analysis actually identifies highly favorable effects of omega-3 fatty acids. So this is the forest plot from the meta-analysis with different types of fatty acids here. I've drawn around the long-chain omega-3 fatty acids, and this is the accumulation of data from 16 studies involving over 400,000 people, looking at the relationship between a high intake of long-chain omega-3 fatty acids and risk of coronary outcomes, showing a significant reduction in risk in people taking a high amount of omega-3s compared with a low amount. The lower slide shows the relationship in studies that have measured omega-3 fatty acids or any fatty acids in the blood or in other tissues and the risk of coronary outcomes. And what the meta-analysis demonstrates with a reasonably high number of studies, 13 studies involving 23,000 individuals, is that having a high amount of EPA or DHA, or EPA and DHA combined, or DPA, is associated with lower risk of coronary outcomes than having a low amount of these fatty acids in the blood. So the Chowdhury meta-analysis actually provides robust evidence that eating omega-3 fatty acids and having a high amount of omega-3 fatty acids in the blood protects against coronary outcomes in the future. So I think at the risk of putting a seal or a label or something on my slide, marine omega-3 fatty acids do prevent coronary heart disease. I think the Chowdhury meta-analysis demonstrates that quite clearly. Although, as I said, the abstract doesn't mention it, and none of the information about the paper when it's discussed mentions that fact. The focus has been on saturated fat. How could omega-3 fatty acids prevent coronary heart disease? Well, we have to look at the risk factors for that disease, which are listed here. And here I show all of the risk factors which are beneficially modified by long-chain omega-3 fatty acids. They include, of course, high blood triglycerides, which have been mentioned, inflammation, hypertension, tendency to thrombosis, vascular dysfunction, and so on. So we get risk factor improvement, and as a result of that, we lower the risk of development of the disease. So I think that is a pretty robust finding. The other part of the story, of course, is what happens in people who are at quite high risk, who have already had a coronary event and then are then treated with omega-3 fatty acids. And of course, the starting point of this is the GISI trial from 17 years ago now since it was published. 11,000 people who had suffered a myocardial infarction but survived, put into a trial that included 2 arms consuming 1 gram of omega-3 ethyl esters per day for 3.5 years, with the trial reporting a reduction in mortality related to cardiovascular disease, particularly sudden death. This shows the survival curves for the 4 outcomes in the GISI trial over the first year of the study. And I think what this slide shows is the 2 curves, the omega-3 curve and the control group, diverging quite early on, within the first 3 to 6 months of the 3.5-year study. So omega-3 fatty acids were having a significant effect on mortality outcomes within months of people starting the study. Those sorts of studies, looking at mortality outcomes in people at high risk of mortality, have again been subject to meta-analysis. This is the Boucher meta-analysis from 2002, with 11 studies of long-chain omega-3s of at least 6 months duration, with about 15,000 patients studied overall, showing a significant reduction in fatal myocardial infarction, sudden death, and mortality. Another meta-analysis from the same group from 2005 included 14 studies of omega-3 fatty acids with 20,000 patients in total, looking at cardiac mortality and all-cause mortality, showing a significant reduction with omega-3 fatty acids. This is the forest plot from the Studer meta-analysis, which compared different lipid-lowering strategies, including omega-3 fatty acids and statins. And if you look at the position of the data here in the forest plots for overall mortality and cardiac mortality, you will see that on average, omega-3 fatty acids were actually more effective than statins at lowering mortality in this meta-analysis. And the conclusion of the meta-analysis, to quote, is that statins and omega-3 fatty acids are the most favorable lipid-lowering interventions with reduced risks of overall and cardiac mortality. So I think this story was very robust until 5 or 6 years ago, and studies published in 2010 and a couple of studies published since then have challenged this view that omega-3 fatty acids can be used to reduce mortality in at-risk patients. Now, of course, any study can be criticized, and there has been criticism of almost all of these new studies for various reasons. And these new studies, which have been neutral, not showing a benefit, but not showing harm either, have very much influenced more recent meta-analyses. So this is one of the most famous of the more recent meta-analyses. It's the Rezos meta-analysis from 2012, published in JAMA. Very interesting, I think, if you look at the forest plots, which I show here, for all-cause mortality, cardiac death, sudden death, MI, and stroke, showing the difference on average across the studies, up to 17 studies in total, between people treated with omega-3 fatty acids or treated with control. So the first thing to note is that the data for all of the outcomes related to either all-cause mortality or cardiac-related mortality all lie to the left, favoring omega-3 fatty acids. Unfortunately, according to the paper, none of these are significant, so there isn't an effect. But if you look at cardiac death, actually the confidence intervals don't touch 1. So this actually is a significant effect that would be reported as significant in most meta-analyses, although this particular meta-analysis says that's not a significant effect for various reasons related to how the statistical significance was identified. But I think looking at this, and we talked yesterday, we heard about optimists. I think looking at this as an optimist, you wouldn't want to throw out the idea that omega-3s might be beneficial here. You might want to look more deeply at why the confidence intervals are so wide. You might want to say, well, we need more studies because we haven't yet got the most robust proof, but there's something that seems to be going on here. So I think we shouldn't throw the idea out that omega-3s can be used for treating cardiovascular disease. And the reason that we shouldn't throw things out is if instead I showed you this meta-analysis by Kasula, which no one talks about, published in a less impactful journal, Atherosclerosis, in fact, a supplement in Atherosclerosis, again with a meta-analysis looking at those outcomes, cardiac death, sudden death, and myocardial infarction were all significantly reduced by omega-3 fatty acids in this meta-analysis. So why are these two meta-analyses saying different things? The reason is the studies that are included in the meta-analysis. And it so happens that this meta-analysis includes the GISI trial and the RESOS meta-analysis didn't. And that makes all the difference here. The inclusion or exclusion of that one trial determines what we say about the effectiveness of omega-3 fatty acids on mortality in people with cardiovascular disease. So I think that's pretty interesting. This is another study that no one will have probably seen. It's not in any meta-analyses because it's not a randomized controlled trial, but it's probably more important than a randomized controlled trial. This is reporting data on real patients being treated with omega-3 fatty acids in a real clinical situation or not being treated with omega-3 fatty acids. This is data from people in the UK looking at survivors of MI, and what they were doing was following the NICE guidelines to treat survivors of MI with 1 gram of omega-3 fatty acid ethyl esters per day. They had 2,500 real patients who had been treated with omega-3 fatty acids as part of their normal care. And they matched these to 9,000 similar patients who they hadn't treated that way. And they followed them for a period of years, and the outcome was mortality. That's all they measured in the study. Were those patients dead or alive when they came back to look? And these are the outcomes here. So this is risk of mortality in patients who were treated with omega-3s compared to not. So there's a 30% reduction in mortality. Patients given omega-3s were 30% less likely to have died in the follow-up period. And this is highly statistically significant because this is a big study. It involves 13,000 patients. They looked at people without diabetes, there was a significant effect. They looked at type 2 diabetics, there was a significant effect. This is a really important study, I think. But it's not a study that I have seen anyone ever talk about or present, and it will never be in a meta-analysis because it's not a randomized controlled trial. It's what happens in real life in clinics where doctors are dealing with real patients. So it's been a little bit tricky to find out why omega-3 fatty acids work well, if you believe they work well, in patients who have already had a myocardial infarction and they lower the risk of mortality. So people have talked about different mechanisms, reduced cardiac arrhythmias, decreased thrombosis, decreased inflammation. And remember the key role of inflammation in driving plaque rupture that I talked about before. And that's something we've been very interested in. So inflammation drives plaque rupture. Omega-3 fatty acids are anti-inflammatory. So we reasoned that one of the explanations could be that omega-3 fatty acids would get into plaques and would stabilize them against this inflammation-driven rupture. And we wanted to study that in real humans, looking at their plaques. And it so happens there are surgical procedures for removal of atherosclerotic plaques, particularly from the carotid artery, that enabled us to do randomized controlled trials to look at plaques in real patients treated with omega-3 fatty acids or not. So I just show you very quickly data from 2 of our studies. This is a paper we published 12 years ago now, 13 years ago now, randomized controlled trial of omega-3 fatty acids in patients awaiting that surgery for removal of plaques from their carotid artery, treated for 6 weeks on average. Patients who were given omega-3 fatty acids had a higher omega-3 content in their plaque compared to the control patients. They had fewer inflammatory cells in the plaque compared to the control patients, and the cardiovascular pathologist said they were more likely to have stable plaques, less likely to have unstable plaques compared to the control group. One of the things we were very interested in was this inflammatory activity in the blood vessel wall that drives plaque rupture as an explanation for how omega-3 fatty acids could stabilize plaques. And there are these proteins called matrix metalloproteins that degrade the cap on the plaque and make it more likely to rupture. So we did a second trial, very like the one I just told you, randomized controlled trial of omega-3 fatty acids versus control in patients awaiting carotid endarterectomy. And we measured in the plaque the different matrix metalloproteinases and other inflammatory molecules that are involved in plaque destabilization. And you see the levels are always lower if the patients received omega-3 fatty acids compared to the control group. So we think omega-3 fatty acids get into the plaque, they have an anti-inflammatory effect in the plaque, which results in increased plaque stability, and that means less vulnerability to rupture. So I think in summary, there's robust evidence that long-term intake of omega-3 fatty acids reduces risk of coronary heart disease because of the beneficial impact on a range of risk factors. So they have a very important role in prevention of the development of atherosclerosis. There's strong evidence from studies conducted pre-2010 for a role of marine omega-3s in secondary prevention. This role has been challenged by some recent studies, and I talked a little bit about that through the impact on meta-analyses. Mechanistic studies, which I haven't really gone into, support a therapeutic effect of omega-3s in cardiovascular disease. Metabolic diseases like non-alcoholic fatty liver disease, which we do a lot of work on now, that increase the risk of cardiovascular disease are amenable to treatment with omega-3s, and that could result in lowered disease burden. And I think ensuring intake of omega-3 fatty acids should be part of the strategy to maintain health and well-being and to reduce disease and disease risk with aging. Thank you very much for your attention.